The OMEMI trial was designed to assess the effects of adding marine-derived omega-3 fatty acids to standard secondary prevention in elderly patients with a recent myocardial infarction. Patients were randomized 2 to 8 weeks after the initial admission for myocardial infarction and randomized to receive either 1.8 gram marine-derived omega-3 fatty acids or a matching corn oil placebo. The predefined follow-up time was 2 years, and serum fatty acids were measured at inclusion and at the final study visit at 2 years to assess adherence to study medications. Our primary outcome was a composite of non-fatal myocardial infarction, unscheduled revascularization, stroke, hospitalization for new or worsened heart failure, and all-cause death. Our secondary outcome was new onset atrial fibrillation. Our major safety endpoint was major bleeding, defined as spark bleeding greater than or equal to 2. From 2012 to 2018, we recruited and randomized 1,027 patients and had follow-up data available for an intention to treat analysis for 1,014 patients. For the primary outcome, 108 patients in the N3 PUFA group, in the omega-3 group, suffered a primary endpoint, and 102 patients in the placebo group suffered a primary endpoint. This corresponds to no significant difference in hazard ratios. Also, analysis for key clinical subgroups and for the individual composites of the primary outcome shows no sign of effect. We also found similar results in the per protocol analysis. For the secondary outcome, we had relatively low numbers. 28 patients in the omega-3 group had new onset atrial fibrillation, and 15 patients in the placebo group suffered a new onset atrial fibrillation. This corresponds to a hazard ratio of 1.84, barely missing the mark for statistical significance with a lower boundary of the 95% confidence interval at 0.98. For the major safety outcome, we had no significant difference between the groups in major bleeding. Also, our serum fatty acid measurements support good adherence in the patient population, with an almost 100% increase in serum EPA in the treatment group. In sum, the clinical implications of this trial, also seen in context with other recent omega-3 fatty acid trials, do not support the use of low to moderate dose of omega-3 fatty acids for secondary prevention in patients. Seen also in context with the findings of the REDUCE-IT trial, which found an increase in atrial fibrillation in patients treated high dose EPA. Our study does somewhat support the concern that high doses of EPA might be a risk regarding new onset atrial fibrillation. Thank you.